Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for the session. My name is Jackie Sable, and I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you are speaking. You can use *6 on your phone to mute and unmute, or you can use the microphone icon on the bottom left-hand side of a computer screen. You may also use the chat for communicating during the session. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible, but we will follow up via email with any open items after the session. If you have suggestions for future topics, please share via the chat tool or email us at echo@psu.edu. Please remember that if and when we discuss cases, there's no personally identifiable information allowed. We are recording these sessions, and we will share all materials, including the recordings, after the session. In the spirit of all teach, all learn, we will be on a first name basis during the sessions. For those of you who are new to Project Echo, Echo sessions typically begin with a brief lecture or presentation, sometimes followed by a case, or other times followed by a question and answer and discussion period. Our session today will include a presentation on medical student value-added roles during the COVID-19 pandemic and beyond, and it will be led by a team of 2 faculty and 5 students from Penn State Health. We'll follow that by discussions. During the lecture, please feel free to put your questions into the chat, but remember that this is an all teach, all learn, so everyone can share both questions and answers. And with that, I'm going to turn things over to Terry. She'll introduce her team and they will go on with their presentation.
Right. So we are delighted that there are so many of you who have joined us for this presentation on student value-added roles in the healthcare system. We are also really proud that we are a team predominantly of students, 2 faculty and 5 students, and we'd like to just take a moment to introduce ourselves. So I'm Terry Wolpaw, the Vice Dean for Educational Affairs at Penn State College of Medicine.
I'm Jed Gonzalo, Associate Professor of Medicine and Public Health Sciences and Associate Dean for Health Systems Education.
My name is David Booth. I'm a 4th-year medical student here at the Penn State College of Medicine.
Hi, my name is Pardis. I'm a 4th-year medical student.
Hi, I'm Caleb Frank. I am also a 4th-year medical student.
Hello there. My name's Dallas, and I am also a 4th-year medical student.
And my name's Paige, and I'm a 3rd-year medical student.
Wonderful. All right, so let's begin. So the healthcare system and medical education, we are going for the same finish line, that finish line of improved patient health and healthcare outcomes. And if that finish line is best captured by the quadruple aim that we have here on this slide, then medical education, the medical education framework must and has expanded beyond a 2-part model of basic science and clinical science to a 4-pillar model that includes health system science and health humanities. In addition to expanding the framework for medical education, the medical education classroom as well needs to expand beyond the lecture hall and the patient examining room. It needs to expand into the healthcare system. What the COVID pandemic has done for us, as tragic as it is to validate this 4-pillar model for medical education and to create a burning platform to utilize this model fully as we design our medical education curricula. But in addition, it's done something more. It has absolutely shown us the potential that our students have, the amazing potential our students have as both learners and contributors when they are a part of value-added roles within the healthcare system. Jed, I'm going to pass it on to you.
Thank you, Terry. I want to thank the Project ECHO team and Dr. Jennifer Krasniewski and the whole team for allowing us to do this today. It's truly a privilege to be here, to be sharing these message and the discussion, and it's more awesome to be here presenting with the students. Mainly, I think our goals, I think this is a great opportunity for us to share some best practices. I see a lot of colleagues that have joined the call from across the country, so it's nice to see all of you, at least via this meeting. So we're hoping that we can share some best practices. We're hoping that we can also raise awareness for the work that we've been doing locally, that if you see a need where we can help, please reach out to us, because we want to be helping fulfill the needs of Penn State Health. And mainly we want to showcase our students. Our students are amazing at this, and you're going to see through the work that they're doing that it's remarkable. As Terry already alluded to, we're in the throes of unprecedented change in medical education, and it's happening in a really unique context of stress and anxiety and uncertainty. But certainly, I will admit that I'm very proud to be a physician. I'm proud to be at Penn State, and I'm proud of our medical education team and the mission that we have been behind for years, but particularly now. And I think you're going to find that the students are intelligent, they're motivated, and these are opportunities amidst this pandemic for allow their motivations to come through. So I'll be brief. I have 2 slides, but I just want to build a foundational framework for what the students will be talking about. And I have 2 conceptual frameworks on the slide. The first is on the left. This is health system science and the 12 discrete competency areas that exist for medical education. And they're concepts that many of us know well: high value care, social determinants of health, informatics and technology, improvement, how the structures and processes of healthcare delivery come together for outcomes. They're pulled together by these cross-cutting domains of leadership, teaming, change management, ethics, and they're cohesively brought together by this large linking domain of systems thinking, which is really a philosophy, a mindset, a set of tools that allows one to see the interconnectedness and the interconnected parts of a healthcare system. So this is a core set of competencies for medical education. It's a core foundational pillar for us at Penn State. The right side shows the idea of value-added medical education. This has been a push in medical education for the past decade and beyond to allow learners to add value to the healthcare system. And the past couple of years has pulled together this idea of value-added medical education, which are essentially roles that can positively impact the healthcare system while also allowing learners to develop competencies in clinical or health system science. And this is a table from one of our research studies that just gives you some samples of what some medical schools have been doing in the past years to allow learners to add value to the healthcare system. And there's many pilots going on at dozens of medical schools. One of the main things we do here at Penn State for 7 years is that all of our learners are in their first year of medical school. They serve in a patient navigator role. They're linked with patients who are in need of help to help them achieve better outcomes. So it's these 2 conceptual frameworks that really, to us, lay the foundational framework for all of the roles and activities the students will be commenting on today. Nearly all of them are mapping to health system science competencies as core for our medical school. And because of that, it's allowed us to really frame these around electives and elective credit. And Terry's been pushing really hard for uninterrupted medical education here, and this framework allows us to do that. And the roles that we have been pushing for years in value-added medical education are really coming together in this pandemic. This is a conceptual framework that we have put together in years past for value-added roles, just to really hit home the point as to what we're trying to do. On the right side is this clinical hub of practice, whether it be a patient, a project in the system, a team, where the structures and the processes and the people come together to help achieve a common outcome or an aim for a patient or a team. This is where the action is happening. But by and large, many of our experiences in medical education place learners on the left, outside of this hub. And it takes them time, there's a chasm of time, and a significant chasm exists for them to actually get into the hub to be a physician in that model. But we can have learners be in this hub to contribute to care. It may not be in the physician role, It may not be in the traditional physician tasks, but they can contribute. And in so doing, we allow learners to gain that motivation to engage in the activities and the tasks. So to us, value-added roles is getting the learners onto this team on the right to actually have motivation or self-efficacy to make a difference. And this is my parting comment before I pass it off to our great students. The COVID-19 pandemic is tragic, but it also further establishes the burning platform for a 4-pillar model of U.S. medical education of the basic clinical sciences, health system science, and humanities, and the professional development of system citizens in healthcare. All of us, this is not just physicians, it's nurses, it's therapists, it's even researchers in the healthcare system, that we are all stewards and ambassadors of a healthcare system, and we need to be in this relationship with the system to care for the system as much as we do for the patients, because they're intertwined. You can't separate those two. We are all citizens of a healthcare country, and that's really what we're trying to develop in our current medical students, but also our healthcare workforce. And in my perspective, this 4-pillar model, what the pandemic has taught us about it is that there is no turning back. We need to embrace this going forward because there will be other pandemics, but there are also many healthcare challenges that exist for our patients pre and post-pandemic: social determinants of health, patient safety, and a lot of the same tenets here still apply. So with that, I'm going to pass it off to David and Partis, who have been our student leads, and then I'll pass it off to Paige, Caleb, and Dallas to walk us through some examples.
Thank you so much, Dr. Gonzalo. So the genesis of this project began March 15th, when Partis and myself, noting the work that other medical students were doing around the country and being eager to harness the unique capacities of the medical students that we have come to know over the past 4 years, we reached out to the College of Medicine administration to ask how we could get involved and how we could help our healthcare system and our community. Upon meeting with Dr. Gonzalo and communicating with other members of the school administration, we quickly came to realize the potential for action based upon the principles laid out for us in our Science of Health Systems course and elsewhere in their curriculum by Dr. Gonzalo and others over the past 4 years of our time at Penn State. After initial discussions, our first step in determining a way forward was to perform a needs assessment in regard to the status of our healthcare system and community here in central Pennsylvania, and attempt to marry those needs with student-solicited, student-identified skill sets, roles, and activities. The fruits of this work were mapped into the 4 categories of activities seen on this slide, namely contributions to community welfare, contributions to healthcare delivery, contributions to the workforce, and contributions to the medical school. The first tasks which were operationalized were those which best married systems-identified needs and student interest. For example, evidence curation and consultation, as seen in Category 2, remote COVID-19 screening, as also seen in Category 2, and contact tracing, as seen in Category 1. Initial and further incorporation of tasks took into account these same principles each time: remote capability for students, the task being aligned with system needs, and educational value for the student. After discussions with the legal department here at the Hershey Medical Center, the determination was made that these tasks are of a different character than volunteering. They represent value-added roles, as Dr. Gonzalo had talked about, as concerns the healthcare system, akin to clinical rotations, where students are going around, they are seeing patients, they are writing notes, and they are participating in other activities which contribute to the healthcare system, for which they receive academic credit. As a result, these activities and these tasks that we had come up with should fall under the same umbrella, and students should receive recompense for their work, namely academic credit. As a result, the tasks were then each folded up into an elective structure by which students could sign up, log their work, and receive academic credit for it. Speaking most broadly, these tasks represent a set of legitimate participatory roles in clinical communities of practice in a time of unprecedented estrangement from our normal roles as medical students. We think this system to be a unique and novel arrangement for both students' education, as well as for their contributions to their healthcare systems and communities in a time of need. On to the next slide. Today, the entire task force comprises 16 tasks with approximately 220 students involved, including medical students, PA students, NP students, and Master of Public Health and Doctor of Public Health students. The tasks themselves span from participation in telehealth remote screening for COVID-19, utilizing the knowledge of students with more clinical experience, clinical engineering, utilizing the engineering and design backgrounds of a set of students in the service of providing material for healthcare workers at Penn State Health, and health policy design, utilizing the public health and health policy expertise of students with relevant backgrounds as well. On to the next slide.
The key to the success of the process was co-production, and this meant making decisions and stepping forward together. From the beginning, this was an endeavor co-produced between the student body, the health system, and the medical school administration. Each component participant, in coordination with the rest of the structure, was involved with idea creation, decision-making, execution, and revision of task activities. The result was an integrated project representing the strengths, interests, needs, and support of each integrated group. For this concerted effort to work as intended, we had to create a structure to best facilitate our goals. In order to administer tasks effectively and to create more efficient, concentrated lines of discussion and action, we organized students into task forces. Each task force is represented by a student task force leader responsible for a task. Student task force leaders are immediately overseen by a panel comprising of COVID-19 student response team leaders, as well as the leaders from the medical center and the College of Medicine. This panel is ultimately responsible for facilitation of team huddles, the reception and assessment of ideas for activities, ultimate decision-making, communication between various interested parties, and continual process involvement. For the next portion of the presentation, the other 3 student members of the huddle team will present more specifics about particular tasks that they were involved in as task leaders.
Hi, I'm Paige, and I was involved in getting the contact tracing effort off the ground. The goal of this effort was to build a student-run team of motivated medical students and nurse practitioner students who would call COVID-positive patients and their contacts as a measure of infection control. We interviewed cases to determine their recent contacts and then notify the contact of potential exposure. This strategy was highly successful in other countries, particularly Singapore, and also recommended by the CDC and the WHO. So on the slide here, you see a diagram of our workflow. Everything below the student task lead is entirely student run. The onboarding team trains new students in proper communication with cases and contacts using a pre-made script. The operation team is in charge of designating cases and contacts to students, and the intervention team is involved in following up with cases and contacts who are having issues gaining supplies such as food and medical supplies. Our oversight is by a physician who's in internal medicine and 2 epidemiologists who were the workforce and guidance in this process. They also acted as quality control measure as they sat on calls with students to ensure that proper information is disseminated and gathered. We were in contact with the Pennsylvania Department of Health, but they stated they didn't have the bandwidth and or the number of people to carry out this task as it's very time consuming and labor intensive. We had a strong body of students who were highly motivated to contribute to our health system in our community. And currently we have 62 students on this task force. This process has allowed these students to work on their communication skills as well as their interprofessional collaboration. And they also were able to identify both systems and patient-specific issues that were arising with a patient who was attempting to quarantine. To date, we've had over 600 calls to both cases and contacts in the Hershey area, and the students were actively involved in modifying and developing this structure you see here on the screen. So next, Caleb's going to introduce the patient navigation that's in our task force.
All right, thank you, Paige. So at Penn State College of Medicine, we have a very robust patient navigation program that students participate in during their first year of medical school. This is a critical building block that introduces students to our science and health systems course. that comes back throughout our curriculum. And just as we as students have been trained as patient navigators during this pandemic, it's lended itself to being able to easily step into the system and where a gap has been identified. And so the goal is to address complexities and deficiencies in the patient experience, whether that is a lack of knowledge of how to navigate the health system, an inability to access transportation, or other barriers that bar patients from receiving the best health care right now. And so students are working alongside nurse care managers to outreach to patients to identify possible barriers to accessing care and identifying social determinants of health, as well as being able to help manage chronic conditions and increasing the health literacy of our patients in our health system. And so during this pandemic, we've identified 3 tasks that all students of the College of Medicine are welcome to participate in, as they've all had experience helping patients navigate the health system. So you can see in the diagram, there's a post-hospital discharge follow-up, COVID-19 positive patient and persons under investigation follow-up, as well as outreaching to nursing facilities. And so one burden identified in the health system after March 15th, moving into this crisis response for the pandemic, was the post-hospital discharge patient population. So commercial payers in our system have increased rates of rehospitalization, and we wanted to reduce readmission rates by increasing the number of touch points the patient population was receiving beyond the first week post-discharge. And so we currently have a group of 15 students calling patients who have been discharged from both the internal medicine as well as family care medicine services at day 7, 14, and 21 in an effort to increase available bed space in our medical center. For our COVID-19 positive patients and persons under investigation, approximately 20 students are interfacing with the contact tracing student group that Paige just recently referenced to ensure that those individuals we're asking to quarantine at home for 14 days both have the resources and the ability to access groceries, cleaning supplies, activities, and even social contact. And just recently, we have a really unique partnership with the PA Department of Health, where rather than reaching out to individual patients, we're also reaching out to facilities, helping both assisted care living and patient care homes navigate the health system. And with that, we have approximately 32 students that are calling over 200 facilities in central Pennsylvania to speak with both administrators and front-facing personal care staff to address the educational needs, to answer clinical care questions, and to help facilitate and give facility policy guidance. Our students are helping these facilities navigate how to move forward and protect other residents and their staff if they have their first COVID-19 positive case, with workflows in place to help out. And we see this as a success if we can prevent even just one person from contracting this disease to save a life, as that is how we can step in to help the system and our community during this time away from our clinical duties. And so with that, I'd like to pass it off to Dallas.
All righty. Hello, everybody. If we could pop to the next slide, please. Excellent. Right. So I'm here to talk a little bit about what we're doing for medical education. And at this point, a fact that I always like to recall is the fact that doctor originally came from the Latin term that meant teacher. And that to me sort of encapsulates one of the many important aspects of what our profession does. As we all know, there is a fairly formalized pipeline, if you will, for how students go through medical school into the residency process onto becoming independent physicians. And ultimately, if there is a halt in this process, especially one with serious ramifications like we're dealing with now during the COVID-19 crisis, a possible interruption, a disruption in students' educations could reverberate not through just months, not through just years, but possibly decades, when you're considering piling this on top of known shortages of physicians that exist. Therefore, a priority of one of these programs that we had was to also make sure that medical education was not interrupted or halted, but that it was modified so that we kept in mind what was best for the safety of medical students and for the institution itself. So to that end, one of the endeavors that we worked in was creating a medical education task force. This group worked to make sure that the education, the training of our medical students continued through this crisis, even though we're currently not allowing medical students to participate in direct patient contact. Really, some of the largest benefits of this come from the fact that, one, students are continuing along their journey to become practicing independent physicians. Two, it gives our more senior medical students experience with working in didactics, if that is something that they're passionate about. And third, and perhaps most importantly for the system, having students work to co-produce these courses can really ease some of the logistical and administrative burden that we have on our own clinician educators. So regarding development, the model that we followed so far is largely that course directors will work in unison with student co-leads to generate materials and make courses that are usually delivered through Zoom. Really, the two models that we have so far worked on rolling out would be, one, a health systems and equities course to take the place of what was much like an underserved rotation. This was meant to sort of prime our phased clerkship students about health systems equities, have them think about the health system as it exists, reflect on how they might change it, and then by presenting them opportunities through all these task force, hopefully have an avenue to act on it. And then what I'm most excited about moving forward is that we have fourth-year medical students currently working with all of our clerkship directors to make sure that we have programming moving forward for the next several months during this challenging time to make sure that they can continue to acquire clinical skills and knowledge, and then hopefully soon re-enter the clinical setting and continue an immersive patient care experience. So to briefly talk about the impact on this from the student perspective, of course there is stress about things like applications and exams and et cetera as we're moving forward. But here at Penn State, continuing your medical education is not one of those concerns. And I want to be very thankful to our administration for working with our students, for being so proactive about making sure that we are smart about how we modify our educational experiences and not just interrupting them. So with that, I can sort of take us into the summary of this quick talk. So really, just to sort of reverberate the points that other speakers have said, health system science education and value-added roles are intimately intertwined with the ongoing pandemic for medical student contributions, no matter what form they may take. This student work, as you've seen from the examples given, can directly align with health system needs and can ease a burden on other parts of the workforce. And finally, these task forces align with core competencies of the medical school and thereby allow the students to receive educational credit. With that, then, I believe we can open up the questions from the audience. Thank you for your time.
Thank you to all of you. That was a wonderful, wonderful presentation. We do have some questions that have already come in, and I'm sure that there will be more. So going from the first one that came in, and I believe this goes back to an earlier slide, a student from SUNY Downstate is wondering how you conducted the needs assessment, what kind of access and transparency the hospital had with regards to its needs.
So I would suggest maybe one of the students want to talk a little bit about that.
Okay, we can do that. So regarding the needs assessment, we were thoroughly, it was a co-production process, and meaning that HMC, the College of Medicine, and the students really were all in lockstep. And so there was a tremendous amount of coordination from the heads of the executive parts of the medical center in performing its needs assessment. So we had regular communication with the executive vice president of Penn State Health and other players in high places who were able to immediately point out and say, having worked with the institution's actual response to COVID, they were immediately able to say what those needs were and how they think students would be able to address it. So two of the tasks that we had brought up earlier on that are particularly good exemplars of this are contact tracing and the evidence curation group. So these were identified needs on the system's part and were communicated to us by the health system, which we then matched again with student interest and student backgrounds in order to help create those two tasks. And so we had found that they were, we were very thankful time and time again to the College of Medicine and to the institution that they were so forthcoming and so willing to walk with students and help us contribute and help them in this time of need. So they were very forthcoming about it and very helpful.
Thank you. So please continue to put your questions in the chat, and I'm going to ask, and I see Jed has already done so, please feel free to provide answers via the chat, but I'll go through those that have not been addressed. So there was also, while you were giving your talk, someone had indicated that they were hoping you would share the contact tracing scripts. Is that something that's available that can be done?
So Dr. Gonzalo and Paige, are you?
Yeah, sorry, I was on
okay.
mute. Paige, I think we can. Paige is working hard on that right now, actually, for a manuscript, because we believe that it could be disseminated for the back end of the pandemic curve and also maybe for future initiatives. It's not just a med student initiative. I mean, anybody, it's probably best if you have a little bit of medical background, but the process they have built is a remarkable thing. And Paige is working on that. So I think, Paige, we can circle back to this individual once we get it crisp and clear to send it off.
Thank you. Again, I apologize if I miss any. Questions are really coming in. A question, did the COVID-focused work replace other curricular content that had been paused, or was this an established swim lane with the individuals who have recovered from COVID-19?
I can take that if that's okay.
No, wait, I just blurred two questions. Can you read them in the chat? Sorry.
The question that I'm seeing is, did the COVID-focused work replace content that had been paused, or was this an established swim lane in your CLIMLA? Okay, yeah. So Mitch, let me know if I'm understanding your question correctly. I would say that prior to this, we had started this COVID work as a longitudinal course, which could be offered for credit. So this was a track that would be available to all students. It would be and available longitudinally. At the same time, it's options available would depend on your course year you were at as a student. So for example, fourth year students also had access to some non-direct patient contact electives, for example, humanities courses or clinical reasoning courses. And then students that were in the clerkship year found their way into the health systems and equities clerkship. And I saw another question about if that was live yet. And yes, we're currently in week 3 of 4. So students have these opportunities to go into those courses and meanwhile, the COVID work opportunities are available longitudinally alongside it.
Thank you. I'm trying to categorize these as they are flying in. A little bit more about contact tracing. One question was, are these solely remote, or are students in person with the individuals? And I think there's another one, a comment that nurse practitioner students are making contact calls to help finish their clinical hours. So any comments about that?
Yeah, so this contact tracing process is entirely remote. We're using a REDCat database to store the cases and the contacts. So when we receive a case from the healthcare, from Penn State itself, we log it into REDCap, and then the student receives a REDCap ID to go and call the patient, fills in all the contacts, and then a different group of students goes and calls all the contacts. We have a case team and we have a contact team to assure there's no breaching of confidentiality between the two teams, and it's all remote.
Thank you. So there are quite a few questions regarding the structure developed that allows students to get core curriculum or elective credit for the activities, followed up with some questions about the M3 students. Did they finish their core clerkship? So can anyone, probably the faculty, address some of those?
Yeah, Terry, I'll go first on this one. Tali is asking the question here about core rotation credit. I think this is it's semi-complex. So I think the answer in short is no. These are longitudinal credits, as Dallas already highlighted. I think my first point is these are not volunteer activities. Many of our students are doing volunteer activities, and we're proud of them. They're doing fantastic work. What was just presented to you was a discrete set of electives. I mean, the amount of time it went through to get this approved by our curriculum management committee was probably the fastest in our history. It went through. I don't think we've ever had this many students enrolled across all 4 years, but since it maps to our competencies, it's elective credit. It's not necessarily double dipping into clerkship credit. But this is my second comment, and then I'll allow Terry to comment too. We are learning so much by these electives. We have been doing value-added roles for the past 7 years here at Penn State, and we've learned a ton. But when you have 220 students across 15 task forces, and you're working with so many students, and you're co-creating, I had 4 calls today with 10 different students on all of this. You learn a bunch on how you can transfer them into what we are calling indirect patient care experiences in the clerkships. So our current model right now, our whole evening is mapped out. How are we going to reconfigure the clerkships during times when our learners cannot be in the clinical environments? And these models, these are prototypes, if you will. I'm looking at Holly too, because I learned a lot of this at Harvard Macy. These are prototypes that transfer into the clerkships that might be specialty specific. So I think the answer is no in short, but in the long term, it is tremendously helpful for us to be transitioning these right into the specialty clerkships. But Terry, I'll allow you to comment.
Yeah, what I would add is that right before the COVID pandemic broke, I had been invited and spoke with the leadership of our healthcare system, Penn State Health. And what I was talking to them about was really working together to find those value-added roles within the system, because people like Jed and I were quite convinced that those roles were there, but it was a little bit of a leap of faith for system leaders to sort of see that. So it is ironic that just before this happened, we were going to create a task force team to try to understand what those roles might be. So what has happened is the pandemic has absolutely just catapulted us into the healthcare system and all the incredible roles that the students can contribute to. So that has really been, for us, an iterative process, beginning really with what I would call almost a pilot. Are those roles there? And then moving from that pilot to, as you've seen here, this really impressive process structure that we can now follow. What I think is pretty impressive is that, especially initially, during our morning huddles, which we have, by the way, with our faculty and students, but also, as they told you, and it is true, the vice president of our healthcare system was on those huddles with us each morning, and we would then say to him, you know, are there some roles you want us to look at? And also, here are some roles we're considering. Are these roles meaningful and value added to the system, and should we move forward? So that's how it went. And then, as Jed said, and that's where we are really in the last sort of week or so, is now saying these are electives today, but these really are about patient care, and the learning is powerful. And we think that we can move them, sort of sustain them, and move them from elective to actually a part of the core clerkship. So that is where we're headed.
Thank you for that. I think that a lot of what was just said was addressing several questions in the chat. Dallas, I'd like to thank you for jumping in and responding to some questions as well. So let me just see where this landed us. So keeping track of student hours and student supervision, did you cover that pretty well, Terry? We're good with that one?
Gosh, I think the answer with hours is, quite honestly, we are just entrusting the students to log their hours. That's really what we're doing. The elective that we have was meant to not be overly structured, so the students can earn anywhere from 1 to 4 credits. And honestly, the reason we even split the credits came from the students, because what they said was, we really want to commit to this, but what if something comes up academically and we can't fully commit? And we didn't want for them to have to drop the elective. So that's kind of how that is. But the students do log their hours, they can present that log, and then it moves forward into, you know, a transcript, elective on their transcript.
So just one thing I'll clarify about this is that what was interesting to Terry and I early on in the process, when we're on the phone with the executive vice president and legal, which is, I'm just thinking conceptually, volunteer versus what part of what we're doing here is that legal is pretty clear. If they're going to be doing work that is aligned with systems needs, it cannot be volunteer work. If this is an extension of the workforce for work that needs to be done, you have to quote unquote pay them, which kind of took me back when I still remember him saying it on the call. You have to pay them financially or pay them with credit. So I think Terry, with her leadership, we were able to do the elective credit. And there's been some challenges when you put that in and you have 350 students sign up. We're not at capacity yet. We've still got, David, how many students do we have yet to fill that we have available?
Yeah, so we were just looking at the numbers. So between all the different groups of students, there are currently 369 students who are signed up to be involved in tasks, with 225 onboarded and actually participating in tasks. And we have yet to really get the MPH and doctoral PH students into that list. So that's kind of where we're sitting.
So the elective was a huge plus, but we're still not at capacity. So if those students want to get elective credit, they see their peers getting elective credit, they would like to be doing the same. But it was billed to us, to Terry and I, that we needed to do this because, again, the nature of the work is in that clinical community of practice. It's aligned with what the Penn State Health needs. It's not that volunteering at a food bank is not important. That is tremendously valuable, but it's a different type of work than what we're doing here, and that gets you into the legal implications and the elective credit.
So I don't know if this one comes back to you, David, or not, but there was a comment and a question, someone impressed by the number of students, and you did give a very impressive number. Are they M2s, 3s, and or 4s, and what percentage are engaged in the work?
Right, so between the 225 students comprising from all of these different backgrounds, so you have approximately 12 to 15 NP students, mostly participating in contact tracing. You have approximately 10 to 15 PA students who are participating in a series of tasks. And we're working on getting the MPH and DPH students logged in and involved. Regarding the medical students, so the class of 2020, the ones that I'm a part of, and we are graduating in a month or so, participation was a little bit less, but between the other 3 classes who are here at Penn State, it's really split pretty evenly. So if you extrapolate, that's probably 200 students or so, subtracting the PA and NP students. It's split pretty evenly. And what we have done, depending on the task, is that if there's a task that requires more clinical experience, for example, remote COVID-19 telehealth screening, we will say in a task description when we are recruiting that this is preferential for students who have clinical experience. And then once those students get involved, we're then able to onboard students from first and second year who have less clinical experience as a kind of tutor and mentorship role for those two different classes. So it's really split pretty evenly between the three classes that aren't my class, as we're off like figuring out how to move and stuff like that.
Well, thank you. There are two different threads going on that I wanted to make sure were fully addressed. So Nikki had started this earlier, asking about curiosity about tracking individual or small group projects. And I know we've had some talks about this, that things that are going on outside of what is organized by the school. And I believe somebody responded that there are efforts to track volunteer work, the non-credit activity. And the activities include the PPE drives, tutoring community children, well checks for community members. So two things. Nikki, does that answer your question? And then the other part is, does anyone have any other volunteer activities that they're aware of that are taking?
Some of the students, some of the other volunteer activities that you all are kind of hearing about among our students?
So I can speak to this a little bit. So we're trying, some of these volunteer activities are actually coming through the health system. They're not being identified as meeting the four criteria of being, they are remote, but of not having much educational value. And so one example is students are working to bring music to inpatients. Students are working on calling patients that are in the hospital without the ability to have visitors. I know that the Office of Student Affairs with Dr. Manny Williams is kind of organizing the volunteer efforts. And kind of keeping a database of what students are up to. This includes babysitting in our community. This includes working at the food bank in Harrisburg, just 20 minutes down the road from us. This includes making meals for those in our community, maybe running groceries. So some of the activities.
Thank you. One more thread and then we'll go to some of the newer questions that came in. So there was a little bit of conversation around students are choosing the role. And I noticed that, Lisa, you're an NP student, that you're able to choose a role, and Daily, it seems like there are options available for other roles. Do you want to speak more about what's going on with the nursing students, or does anyone from our panel have anything?
Yeah, I can address that. So when we were pulled out of clinical, we were given the option to join with the medical students. And I have been doing the contact tracing calls. There's other available roles or duties that have become available, such as calls for plasma donation. And it just seems like every day there's something else, that a need is brought forth and needs addressed.
Thank you.
You're welcome.
All right, so we have some new questions. Are there concerns about students supervising other students?
Yeah, I just typed this one out. Yeah, so the situations in which students are helping to onboard other students in, for example, contact tracing, is that they are helping them go through the training. But when students are participating in the actual task itself, there's always an experienced provider and someone with, relevant experience in the area who is serving as the ultimate supervisory role. The only time that students are kind of helping in that mentorship capacity is during the onboarding onto a task. They never serve directly in a supervisory role for students participating in the tasks.
Thank you. Holly wants to know, can you speak to the med ed piece a bit more? Are senior students teaching clinical content to M3s displaced from the wards or something else?
So let me, no, absolutely, Dallas, go for it.
Right. So I want to start off with that by asking what one of our staff, Dr. Eileen Moser, posed to us when we started working on this project. And this gets to the essential question of what is the essential purpose of the clerkship experience for medical students, and what exactly do they learn from it? Very early on in our discussions about this, there was talk about what we got out of the experience. And one thing that I reflected on was the fact that a lot of material could simply be learned by a student reading a textbook on their own, things like the basics of pharmacology, etc. But there are other much more vital skills that we want to try and give to these students so that they're better prepared and can hit the ground running when they re-enter direct patient care. Elements like this that would be really important would include, for example, clinical reasoning skills, practicing patient presentations, using the electronic health record, using exciting mediums out there to develop and further grow empathy and interviewing skills, and as we develop the technology, engagement with telehealth tasks. I can speak specifically to some activities we're tentatively talking about for the psychiatry clerkship, but I hope in general that sort of answers the flow. Basically, the fourth-year medical students would be acting as co-producers of the content with the clerkship directors. And if down the line we think that there would be value in adding a little bit heavier of a didactic component of the fourth year's teaching to the third year students, that's something that there could be value in implementing.
This is Terry. I think what I would share here is the true co-production that happened. I have been involved in medical education and had students working with me in various ways for a long time. I have never had this level of co-production, and it is remarkable. I think it's partly because everything, of course, with the COVID pandemic has been quick and unpredictable. And so, Dallas, you were involved. We had to create a course, as the students told you, that took the place of what would have been a sort of a third, fourth year clerkship. We had about 2 weeks to do it. And so we truly worked absolutely, every night on Zooms, and we were all in the same Zoom. We were thinking it through together. Students were a part of the sessions as far as some of the, the actual content that was being delivered. And that was really quite impressive. And similarly then, because that was so successful, as Dallas said, in moving to the clerkships, we immediately created co-production clerkship and student teams. So they are at the design level right now, as Dallas has said. And what I can tell you is that, and we suspected this, the ideas that are coming out are greater because of the co-production. There's just no doubt in our minds that we are so much better because of the partnership and the co-production. And I think the ability of the students to take us outside our comfort zone in this time when we need to do that is really one of the most impactful parts of this.
Terry, if I could just comment too, I'm just repeating what Terry just said because I think it's spot on. The pandemic itself has been an innovation sandbox for co-production. It's the clerkship. We had another course that was going, that was co-produced. All of the entire process here that we just presented, co-produced. The Taskforces, I mean, these students they're an extended workforce, but they are collaborating one-on-one with these leaders. They're co-producing a process because contact tracing, for example, Chris Shimana is a general internal medicine physician. I remember the morning he called me at 6:30, he said, Jed, I have no idea how to do contact tracing. It's the right thing to do. Can we form it? And 4 hours later, he's on a call with students and they are co-producing a process. So every task force here is co-produced. And I'll just highlight the fact that Paige and I were on a call at 3 o'clock today about thinking about co-production in medical education because of all this. And my meta thought here is that I have never been closer to students in my life. I mean, there's a huge irony and paradox that you walk into classrooms and you're close to students, but it has brought us together even though we're not physically sitting next to each other. It is a remarkable and almost surreal experience as a medical educator.
Well, thank you for those wonderful comments. It's really, really fantastic hearing all of this. Can we go back to Huddle? activities quickly, and if these were already discussed, tell me to be quiet. Are there didactic elements to the credit-bearing opportunities, reflective sessions, anything more around the huddle activities?
So let me just start with this, and then I'm going to send it to the huddle, because I want to distinguish this from service learning. Not that there couldn't be some overlap, but the piece that Jed brought out earlier, and I do want to share with you for us, is that the activities that we're talking about predominantly here, if we did not have credit for them, from a legal perspective, we would have had to quit them. So that's really, I think, the piece to understand, is that these activities are actual work. They're actual work that's going on in the system. And if it wasn't the students doing it, then someone else in the system would be doing it. So they are really engaged in the flow of work and the production of that work. I'll go ahead and let people talk about the huddles as well.
Yeah, so Dallas, go for it.
I'll just add, I heard something about the question of a critical reflection element to it. I will say that we are asking for students that participate in these activities that they do submit a critical reflection of these activities that the lead faculty overseeing will read and review. That's one element that we do have. That's also another measure for oversight.
And they also have entrance readings as well as the onboarding process for their specific tasks too. So there's a front end in terms of the initial training that they go through, then there's participation in the task, and then there's a critical reflection piece that they're expected to do as well. So kind of throughout their experience on the tasks, there are educational opportunities and reflective opportunities integrated into them.
Thank you. So a lot of praise coming through, phenomenal work. So we have about 5 or 6 minutes left. If there are other questions or comments, please put them in the chat and we can continue to address them.
I saw Tali ask a question of, were all students expected to participate, or is this optional? And I want to emphasize that this was something that is purely optional and something that we offer to our fellow students. I will add that at the start of this process, there was even a small degree of controversy in that we had such an outpouring of massive student support that some students were honestly frustrated they couldn't find more opportunities to participate in these processes sooner. And I think that speaks to the dedication of this student body and the skills they developed to have meaningful impacts moving forward.
Thank you. Thank you for catching that comment or question. There was another question that came in regarding the credit bearing process. How do you structure it? What determines 1 credit versus 4?
I can just take that. We created just criteria around the credits, around hours of contribution based on some of our other courses that we had. And then as everything I think is going on here iteratively, we will probably revise that moving forward. But we did define the 4 credits as greater than 40 or greater hours of contributions.
Okay, thank you. And there's a pondering thought in the chat that I will read out. Sometimes I wonder if value-added medical education is hard to accept for medical schools because it requires taking students' analysis and critique of the healthcare system status quo seriously, which can make hospital systems nervous. Any comments?
You know, that's it. Yeah, I'll take that one. And we've published a little bit on this the past couple of years in the context of patient navigation. And I think it's a great question. I think we probably haven't seen that as much. The resistance might come from health systems leaders are all behind health system science and, at least in theory, behind value-add med ed. I think it comes down to, and again, everyone on the experienced people on the phone can comment too, I think it comes down to preceptors in the clinical microsystems those who have been in medical education for years, who might be more apprehensive to think about new or different ways of engaging learners in a process. And it's not a judgment on those individuals, but I think it's just harder for people to empower students when we have been in this type of routine of medical education for a long time. And we learned that through patient navigation. Some of the easiest inroads we made in developing these models were with people who had never been around a medical student. They got the concept immediately and they bought in. So I think that what the pandemic partly is teaching us is that maybe the way that we have gone about our business of medical education, we need to challenge it. Clearly we are. I mean, it's been upended in many ways, but how are we going to keep the fire burning as we incorporate the good, get rid of the bad, but think differently through 2021 and 2022? And I think this is a time that's allowing us to re-examine that.
Sounds like how do we keep the fire burning is a future topic for one of these sessions. So we have 1 minute left, 2 minutes left. Any last comments, please put them into the chat. We will, if there are questions, please put them in and we'll ask our panel to address them via a follow-up email. I would like to thank everyone for joining and give kudos to this team. It was probably one of the most engaging echoes I've been on, and you are all you're pros at the whole echo model. You did wonderfully. So some final comments real quickly. As mentioned earlier, all materials will be shared via email. And we hope that you'll continue to join us for future scheduled echo sessions. We do send emails out on those, so continue to watch for additional sessions as they're scheduled. And before we log off, we will keep that chat there and capture any questions. And thank you all for your participation.
I can address the last one on there that just came up.
Thank you.
Yeah, so one of the things that we've really been focusing on in the past really 2 weeks has been how do we channel the enthusiasm and skills of students to find systems needs, and how do we create tasks around that? And so what we've developed is a structure by which students, we as a student group and administrator group, have created a mock proposal, which if students have an idea for a new value-added task that they want to add, they're aware of the 4 pillars that are required to meet elective criteria. And they are given the tools to basically go out and create their own task. And if it meets the 4 criteria and they have adequate supervision and it's recognized as a system need from a faculty member, then we incorporate it and we recruit students for it. And so that's how we have worked to, again, we've really focused on co-production and harnessing the enthusiasm and ingenuity of the students. And this is how we have done that, as the majority of the tasks now are coming from student ideas and student interests as opposed to being given to us from the healthcare system administration. So that's how we have done that. So yes, they can.
Thank you. It is 5 o'clock, so thank you very much for your participation, and we hope to see you again.